We'll move on to the second presentation from Medicine 2 by Dr. Feneeshiah.
Good morning, everyone. I'm presenting on behalf of Medicine 2 on the topic, the dotted story. So I'll start with a question. So you can see 4 pictures. Can you correlate with any of the known syndromes? So we'll put a slide over. Have a look at these pictures. So the first one, this is the second. The third. And the fourth. So the code is 1522861. Okay. So what does the first picture show? Something with blood pressure and something with a chest X-ray finding, and this thing is a peripheral angiogram. So this is somewhere around the renal vessels, and this is a renal artery Doppler. Zoom it. Okay, I'll move on to my presentation. So I'm presenting Mr. D, a 70-year-old gentleman who presented with complaints of sudden onset breathlessness since 6:30 p.m. on 13th of July 2023. So he was apparently well till then, after which he developed acute onset breathlessness, which rapidly worsened over 1 hour. It was associated with excessive sweating. He was immediately brought to the hospital where his sensorium dropped just before ED, and he was brought in an unconscious state to the ED. However, there was no history of any chest pain, palpitations, fever, cough, coryza, no history of any loose stools or abdominal pain. There's no history of any decreased urine output. He was compliant on his medications. So past history, he was a known diabetic for 14 years. And for the past 8 years, he's been under follow-up with one of our peripheral hospitals, and he has poorly controlled blood glucose levels, and he has complications of non-proliferative diabetic retinopathy, diabetic neuropathy, nephropathy, and he's on insulin injections for the past 3 years. And he was also hypertensive for the past 14 years. And while he was on follow-up, his blood pressures were always on the higher side, and he was requiring multiple classes of antihypertensives for the same. And lastly, before all of these events happened, he was requiring almost 4 to 5 classes of antihypertensives, and still his blood pressures were on the higher side. And in 2016, he was found to have carpal tunnel syndrome, which was managed conservatively. And from February 2018 onwards, he was developing on and off pedal edema. And by mid-2020, he started developing breathlessness on exertion. And his effort tolerance also started decreasing. He worsened from NYHA class 1 to 2 in 2020. And from then on, he slowly his tolerance started decreasing, and it's around NYHA class 3 to 4 over the past 6 months. And he started manifesting symptoms of heart failure. And he also had two recent admissions in the past 6 months, one in the month of January, where he came with complaints of acute onset breathing difficulty. At that time, we diagnosed him as acute decompensated heart failure, probably due to NSTEMI. He was breathless and he was intubated, shifted to ICU. He developed oliguric AKI, which was attributed to cardiorenal syndrome. He received dialysis. He was started on dual antiplatelets, statins, and anti-failure medications, and he was discharged. And he was compliant on medications as such. And 2 months later, in March 2023, he again was admitted with complaints of typical angina, and at that time his cardiac enzymes were elevated, and at the time the diagnosis made was NSTEMI. Again, he had sudden worsening breathlessness with pulmonary edema, and this time we tried to do a coronary angiogram, but since his renal functions were worsening, that was not feasible at that time. And the third admission is the one which I described. So otherwise, he's a reformed smoker and alcohol consumer. On heart failure medications, he was compliant over the past 6 months, and there's no significant family history. So when he presented, he came in respiratory distress, and vitals at presentation, his blood pressure was 140/90, saturation was 29%, pulse rate was 88, JVP was elevated because his saturation was 29%, and since sensorium was dropping, he was intubated in ED itself. He was pale. There was bilateral pitting pedal edema, but no icterus, clubbing, cyanosis, or generalized lymphadenopathy. Respiratory system examination wise, there were bilateral extensive crepitations heard in all lung areas, and cardiovascular system wise, S1, S2 normal, no murmurs or no LVS3, abdomen soft, non-tender, no hepatosplenomegaly, no renal angle tenderness, no renal bruit heard. And CNS examination wise, his sensorium was low, and otherwise, the differentials which we considered were, in view of a sudden onset breathlessness and features of fluid overload, we thought of acute decompensated heart failure, ACS, STEMI or NSTEMI, recurrent tachyarrhythmias and valvular heart disease, acute pulmonary embolism, and worsening CKD. So investigations wise, when he presented to the ED, he came in metabolic acidosis 6.96, and he was hypoxic, so he was ventilated. And then investigations wise, he had a HbO of 10.5, normal counts, normal platelets, serial cardiac enzymes were sent, which were elevated, NT-proBNP was high. He had normal electrolytes, renal functions, urea was 71 and creat was 2.58, liver function test and urine analysis were normal. So this is his chest X-ray presentation. It was showing battering appearance of pulmonary edema. So we did an ECG which showed heart rate of 72 per minute, regular sinus rhythm, no STT changes. There were no serial changes in 2 ECGs. Echo was done, which showed left ventricular hypertrophy. There were no regional wall motion abnormalities, and his ejection fraction was 61%. And because he has come with recurrent episodes of pulmonary edema, and his hypertension was also not well controlled, we did the renal artery Doppler, which was showing features suggestive of right-sided renal artery stenosis with smaller right kidney with grade 2 to 3 renal parenchymal changes. And this was showing a Parvus et tardis spectral pattern. So final diagnosis was acute decompensated heart failure with preserved ejection fraction. Flash pulmonary edema and renal artery stenosis, we are thinking of a Pickering syndrome, type 2 diabetes, hypertension, and CKD. So coming back to the first question which I've asked you. So the sphygmomanometer which I've shown is to see the hypertension. The chest X-ray is to show pulmonary edema, and our patient had recurrent episodes of pulmonary edema. And the angiogram over there is showing bilateral renal artery stenosis, and this is a Parvus et tardis pattern on a renal artery Doppler. So this syndrome is called Pickering syndrome. It's where patients present with recurrent episodes of pulmonary edema, and there is an associated renal artery stenosis. So I'll be talking about Pickering syndrome. So this recurs to recurrent flash pulmonary edema and hypertensive episodes, largely resulting from bilateral renal artery stenosis or an unilateral renal artery stenosis with solitary functioning kidney. So this was first described by Thomas Pickering in Lancet Journal, where he observed 11 patients with who had arthromatous renovascular hypertension who presented with multiple episodes of pulmonary edema, out of which 7 of them had both renal artery stenosis, 2 had stenosis of renal artery with the solitary kidney, and 2 had unilateral cirrhosis with intact contralateral kidney. And he also found that after successful revascularization of the renal arteries, there is improvement in the blood pressure control and renal function, and that virtually eliminated pulmonary edema. And while concluding the paper, he also mentioned that in patients with recurrent pulmonary edema with bilateral renal artery stenosis, renal revascularization can prevent further episodes of recurrent pulmonary edema. So how this happens is when there is bilateral renal artery stenosis, there is hypoxia to the renal vasculature, which in turn causes activation of RAS and the sympathetic nervous system. And because there is activation of RAS, there is more aldosterone pathway. There is increase in blood pressure, which can increase the left ventricular end diastolic pressure, which can aggravate the pulmonary edema. Because of the failure of pressure natriuresis, there is increased sodium and fluid retention, which can again aggravate pulmonary edema. There is also increase in factors like AT2 and ET1, along with increased catecholamines, which can cause abnormalities in the perfusion, in the capillary perfusion. So there is the set of cardiovascular risk factors in the background of risk factors like arterial hypertension, diabetes, and smoking, predisposed with hypertension and bilateral renal artery stenosis. This is again precipitated by increase in blood pressure and volume overload. This results in episodes of flash pulmonary edema. So the diagnosis for the gold standard is the renal angiogram, but a Doppler ultrasound is as effective as the renal angiogram. So they compared the percentage of stenosis which was detected by the ultrasound and the ones by angiography. So you can see mostly, so the 0 to 59%, almost out of 64, 62 could be picked up by ultrasound, and 60 to 99%, almost 98 is picked by the ultrasound, and for 100% stenosis, out of 24, 22 is picked by the ultrasound. So it's as good as a renal angiogram. So management, so there's 2 phases of management. One is the acute flash pulmonary edema phase, where you manage the patient with loop diuretics, positive pressure ventilation, and second is the definitive management, where you do renal revascularization. So the way to do the renal vascularization, one is the surgical one and the other is the endovascular one. So this is a set of studies which compared surgical versus endovascular. So most of the revascularizations are done endovascular, and more than balloon replacement, the stenting is more commonly done, and the response rate is around 70 to 85% across all studies. So coming to our patient, he was managed with diuretics and positive pressure ventilation during the acute episodes, and then he was referred to cardiology. So he underwent coronary and peripheral angiogram, where he was found to have left main and double vessel coronary artery disease, and there was bilateral renal artery stenosis. PTA with stenting of the bilateral renal artery was done, and he's planned for IVL assisted left main LAD and LCS bifurcation PCI. So this is the trend of creatinine from January onwards. So he had acute periods of worsening, but after the PCI, with after the stenting, which was done on 25th, it has stayed at a lower level, and further reports are yet to be followed up. And learning point is, in patients who present with risk factors of atherosclerosis and multiple episodes of flash pulmonary edema with hypertension, the diagnosis of renal artery stenosis should be considered.
How many antihypertensive medications was he originally on?
He was started off with ARBs and CCBs way back in 2015. So around by 2022, he was on a diuretic, calcium channel blocker, beta blocker, and alpha blocker and a venodilator.
He had a resistant hypertension.
He had a resistant hypertension.
Any other questions from the audience?
So I think what Esther is trying to get at is even if when they're elderly, if you have to continuously go up on antihypertensives and if they're requiring 5 antihypertensives, you don't wait till they come with multiple episodes of flash pulmonary edema. Looking for a cause for the resistant hypertension and probably will be able to. Looking for the renal doctor is probably something worthwhile. It's easy enough test to do. It's not very expensive. I think we would have possibly gotten those diagnoses earlier. So we have to keep going up on antihypertensives because he's been admitted with us. And we were the ones who started his antihypertensives, right? But we had to keep going up on antihypertensives. So a lot of the times we may do renal artery doctors only in young hypertensives, no? But if you keep having to go up on antihypertensives for people, so he was on 5. So 2 of the doctors.
Other questions or comments?
Any explanations for why do they have fluctuating hypertensions and intermittently going into flash pulmonary edema, where the mechanism is a constant pathology which is there?
So far, he was compliant on medications, so non-compliance cannot be a cause. The other thing is, he had maybe there is like maybe he was not on fluid restriction as he would. That could probably be one of the factors, but being on a strict fluid restriction is one thing to prevent all of this. So that part could be a cause, like he may not be on strict fluid restriction. And thirdly, we ruled out infection, so that could not be a triggering factor for this pulmonary edema as such.
So most of these flash pulmonary edemas you're saying is most probably it would be any of the risk factors for heart failure.
Yes.
If those are not taken care, rather than anything physiologically or biochemically which is fluctuating, pushing them into accelerated hypertensions in between and pushing them into flash pulmonary edema. Because the renal artery stenosis is constantly there, which will be the reason for the resistant hypertension requiring increasing doses of antihypertensive, and something is decompensating. Is there other mechanisms by which there may be aggravations of the blood pressures intermittently? And why is the term Pickering syndrome?
It's named after the Dr. Thomas Pickering. So he was the one who described this in 11 patients. He observed that this patients who had recurrent flash pulmonary edema along with hypertension had renal artery stenosis, which can be unilateral or bilateral. The unilateral ones are usually associated with a single functioning kidney. So this is the paper, sir. It was published in Lancet in 1988.
So here your question is, look, anybody who has risk factors for atherosclerosis over a period of time can develop a secondary atherosclerotic renal artery stenosis. That's a known fact. And so in any patients where your requirement of antihypertensive starts going up, you have to think of a secondary renal artery stenosis, unlike the young patients who may have other causes for renal artery stenosis. So in that background, what is unique about Pickering syndrome, which is clinically being described having recurrent flash pulmonary edemas? Is there anything unique about these manifestations that he is describing which is different than a usual secondary atherosclerotic renal artery stenosis?
No.
It's the same subset.
Same.
It's just that if a patient presenting with a flash pulmonary edema, you should think of a renal artery stenosis, and that is what he has demonstrated in his series.
Thank you, Dr. Feneeshiah. Our next presenter is Dr. Mayvik from Medicine 3.